What are the clinical signs you'll see with femoral acetabular impingement syndrome? Well, you can use hip impingement tests, okay? And this was a pretty cool study by Paulson et al. In 2020. They're looking at sensitivity and specificity of a bunch of different special tests for the hip. And what they found were a couple sensitive tests, which are going to be the anterior impingement tests, which basically have a patient lie on their back. You flex their hip to 90 degrees, you internally rotate the hip, and then you horizontally adduct the hip, okay? If this creates the patient's specific symptoms, right, the reason why they came in to see you that day, that's going to have an 80% sensitivity and a 26% specificity, right? So that's a very sensitive test. It's going to be good for ruling out FAI syndrome. It's not going to be very good for ruling in FAI syndrome, okay? The other sensitive test was the Faber test, which is flexion, adduction, internal rotation. Basically, the patient lies on their back. You flex the hip maximally, internally rotate the hip, and adduct the hip, right? And if that reproduces the symptoms, 80% sensitivity, 25% specificity. So again, terrible for ruling in FAI syndrome, but great for ruling out FAI syndrome. How about specific tests? How can we rule in FAI syndrome? Well, the one test that was actually pretty good and had a high specificity was going to be internal rotation range of motion testing. And what you have your patient do is have them lie on their belly, okay? Bring their knees together, flex the knees to 90 degrees, and then maximally internally rotate both hips, okay? Now, if you have limited range of motion and or pain, that's a positive test, which has a 29% sensitivity. So terrible for ruling out FAI syndrome. It has a great specificity of 94%. So if this test is, positive, it's a good likelihood, 94% likelihood that person does have FAI syndrome. Next, I want to talk a little bit about the Faber test because that's actually a really popular hip pathology test, but it doesn't have a very good sensitivity or specificity. In this study, the Faber test had a 54% sensitivity, so it's basically a coin flip whether or not this test is accurate, right? And has a 38% specificity, so even worse for ruling in pathology. So if you're relying on the Faber test to be good at picking up pathology in FAI syndrome, not very good, okay? My thought, and I'm not exactly sure why this is, but for the majority of folks that have FAI syndrome and associated labral pathology, they have most of their issues within the anterior superior or the top front part of the joint, okay? Now, when you do a Faber test or anterior impingement test, you are compressing the front of the joint. When you do a Faber test, you're not necessarily doing this. I think this is one of the reasons why it's going to be a little less sensitive and a little less specific. But again, that's just a guess. What other clinical signs are you going to see with FAI syndrome? Well, for one, typically there's going to be limited range of motion. Now, there's mixed evidence on whether or not this actually occurs. Okay, so take this with a grain of salt. But typically, the motions that are going to be limited are going to be hip flexion and hip internal rotation, or a combination of both. And the reason why this is because most hip pathology is in the front top part of the hip joint. And when you combine hip flexion with internal rotation, it takes that cam morphology and pushes it directly up against the acetabulum, creates symptoms. So if your body doesn't want you to do that because there's an injury there, it's going to limit hip flexion and hip internal rotation. This is exactly the reason why when folks have FAI syndrome, I don't like cranking them into hip flexion and hip internal rotation. Unfortunately, that's a pretty popular treatment for this online. And I think it's probably more of picking the scab than it is helpful. But that's, again, my opinion. Okay. What else are you going to find? Generally speaking, there are abnormal movement patterns. And this happens with any sort of pain problem. And the idea is your body is potentially trying to protect you. So you move a little bit differently to avoid irritating the joint. Okay. So let's say you're going for a squat. If you have your patient perform a squat and they have FAI syndrome, you might notice a weight shift away from the painful side. You might also notice a bit of a posterior pelvic tilt. Okay. So the individual tries to tip their tail a little bit, kind of like a dog that's scared, takes its tail, puts it between its legs, posterior pelvic tilts, and they can often do this on one side. It's really interesting to watch folks with FAI syndrome move, right? You may also notice that there's going to be some sort of toe out or knee out on the symptomatic side. Again, they're probably trying to avoid loading that irritated spot in the front of the hip. You'll notice the hips turn a little bit, or you'll notice a little bit of knee out Again, this is all probably because they're trying to avoid loading the irritated position. The other big thing that you're probably going to find with FAI patients is hip weakness. Okay. I'm taking these numbers directly from a research article, and I think it's a pretty good piece of information for physical therapists to know, just because I don't believe this is common knowledge. But FAI patients had significantly lower strength than controls for hip adduction, 28% deficit, flexion, 26% deficit, external rotation, 18% deficit, and abduction, 11% deficit compared to the opposite side. Okay. Now, one of the reasons why I think this is important to understand is because typically with physical therapists, we're always concerned with strengthening hip abductors and external rotators. It's kind of like the bread and butter for physical therapists. However, there's actually a more significant weakness into hip adduction, okay, and hip flexion, which are two motions we probably have to help to restore after someone has FAI syndrome, especially after they've had surgery. We just have to be cautious when we start to push this because we don't want to aggravate that healing hip, okay? The last thing that we should be doing is trying to rule out other pathology, okay, that could be masquerading as FAI syndrome. So that could be a groin strain, that could be greater trochanteric syndrome, that could be a hip flexor strain. We just have to make sure we do our due diligence to rule out other pathologies. So here's what I want you to do next, guys. If you enjoyed this video so far, I have an entire course. It's free. It's called the Fitness Pain-Free Mini Course. And we go over 3 lessons going to help you take a lot of this information that we went over so far and put it into practice. The first lecture is called Why We Need a Better System. So first and foremost, the way we treat fitness individuals, all right, athletic people in the gym from a physical therapy perspective is pretty much broke, okay? So we need a better system to serve the folks that are in the gym that get hurt, they want to get back to training, all right? Lecture number 2 is called 7 Reasons Why People Get Hurt in the Gym. And essentially, we have to know the reasons why people get hurt in the gym so we can keep them safe in the future, right? And when they get hurt, we have to know why and how to get them back to training in the gym. Okay, so a thorough understanding of this is very, very important. I actually have a really cool infographic that goes along with this lecture that you get for free as well. And lastly, we go over a case study of how to get someone out of pain and back to training. So these principles are all phenomenal, but we don't actually put it together and you don't understand how to create a program to get people back in the gym and keep them safe for the long term, then we lose, right? So I'll put a link in the show notes for this. It's a Fitness Pain-Free Mini Course. Definitely check this out.